Hello, everyone, and welcome to the Lori Clark Show. This episode of my podcast is brought to you with the help of Zoom Us, a video and audio conferencing interface. It's important to know that I'm in no way sponsored by Zoom. I just want to tell you how much I love it. It is very reliable, easy to use, and provides excellent audio and video files that my team and I produce to share the power of story with you. Another non-sponsored, couldn't do without, but just have to tell you how good it is Squarespace. When they say it is the all-in-one platform, it really is true. I go into the back end of my website multiple times a day, adjust things, post podcast, add links, and look at our show's analytics, which all sync across my devices. And when I need an image, Squarespace provides an excellent resource that's powered by Unsplash. Now for my most favorite feature, the Squarespace app. Being a working mom, there never seems to be enough time in my day. So when my daughter's in ballet, I sit in my car and upload, post, and manage everything on my website from the app. It's really cool and seamless. Squarespace is really, really simple and very dedicated to helping me create a brand of excellence. So with that, big shout out to Zoom, Squarespace, and Unsplash. Thank you for helping me tell people's stories. With that said, let's move on to the best part about today, the show. Please allow me to welcome my next guest on The Lori Clark Show. Kjersti completed her Bachelor's of Human Kinetics and Master's of Physical Therapy at the University of British Columbia and continues to take courses to further her professional skills. Most of her training includes manual therapy, orthopedic division, functioning dry needling. Okay, I'm just saying, it hurts when you... I'm totally wrecking my own introduction, but I've been dry needled before.
Yeah. Me too.
And it should be like dry pain needling or something like that. Ooh. Anyway, you also have completed a course in Pilates and has done additional training in the fields of pelvic health. Kjersti joined the team at Diane Lee and Associates, a clinic in Vancouver, and specifically in the South Surrey area, and offers a functional whole body approach to understand how certain problems in the body can impact other areas of the body. So I want to welcome you, Kjersti. Thank you for coming on the show. I am so excited to have this conversation.
I'm so happy to be here. I'm so thankful that you invited me on as well.
Well, it all started because, you've been treating my pelvis.
That's right.
Yes. And, I came in and originally I saw Kathy, another colleague of yours, for a knee injury that had happened. And she said to me, it doesn't seem like your pelvis is right. And I was like, really? Yeah. And so before I treat you further for your knee, I need to send you over to the pelvic floor. And I have to tell you, the first day I almost cried. It was incredible. So 10 years ago, I had our daughter and my pelvis was very troubled at that point. And she being my fourth child, I had some pain and some problems while I was pregnant. And then, of course, went into labor and I did not vaginally deliver the baby. She was my very first cesarean section after having 3 additional children. So you looked at my pelvis and said, okay, so what seems to be going on? And I'm like, well, shame. I felt shame. I felt like, I remember saying to you, I don't really want to tell you that, I have a hemorrhoid, that I feel like I'm constipated. I have problem having bowel movements. I don't know what's wrong with me. Sometimes I think, well, maybe I have cancer, maybe I have something crazy. And you said, well, let's just start you on with an ultrasound, which was really, really cool. Let's walk through our encounter and why you do what you do. And maybe you could introduce us to why you, on the very first visit, would do an ultrasound with someone like myself.
Absolutely. Yes, Lori. So typically when someone comes in the door, the first thing that I will ask is, what's your story? What's your meaningful complaint is how we phrase it. And the goal of that question is really to find out what is the most important thing to you as the patient. And that helps me to really guide and direct my assessment and treatment. So for you, there was something going on with your rectum. You were feeling some difficulty with bowel movements. There was something not right. And of course, when it comes to that area of the body, we don't want to talk about that.
No, I felt incredible shame about it. I was like, is it wrong that I named my hemorrhoids Hemi and Royd?
Awesome. I love that.
Well, I had to make it funny and I had to make it feel like it wasn't embarrassing.
Mm-hmm. Absolutely. And these are the types of things that we just hide and then we worry about them. Like, oh, what is that? Is that cancer? Is that a lump? What is that? Rather than really just saying, let me go talk to a health professional about it. And good for you and good for all of the women that I see to just open up and be able to say, when I ask, hey, like, how is it when you have a bowel movement? How is that for you? And I think that those are the most interesting conversations because what is normal? We don't really talk about stool quality and, how is your bowel movement? How frequent are they? And these are really important things in terms of your health. So those are some of the most challenging conversations for people. But, I think it really tells us a lot about what's going on with someone. And so for you, Lori, you were noticing, we talked about what was happening when you were having a bowel movement and you were feeling like it was incomplete voiding, right?
Yeah.
Sometimes you would have a little bit left over and even that, telling someone, oh my gosh, it's strange when I have a bowel movement and being open about that is so important. So we discovered with you that there was a little bit of a weakening of the back wall of the vagina, and we call that a rectocele. And it's a type of pelvic organ prolapse, but again, that's a scary word. And a lot of people are just terrified when we talk about that. And I think the importance of us having this conversation is to really kind of normalize that topic and say, wow, 50% of the women who have had children have some degree of pelvic organ prolapse. So if you're in the line at Starbucks, count the women, about half of them have some degree of asymptomatic or symptomatic pelvic organ prolapse. And that's huge. So it's not that, you're just alone. And it can be varying degrees. And it can be something that you've just totally normalized. I think it's normal that I pee when I laugh, and I think we kind of talk about that and joke about that a little bit, but there's always that seriousness underneath that, wow, is that really wrong? And is that damaging to my bladder? Is that going to get worse as I get older? So there's a lot of these conversations that we really should just start talking about so that we can start to troubleshoot and help people feel better.
Well, and the thing about when you jump on a trampoline or you cough or you laugh and then you pee, it's like as a woman you go, how mortifying.
Yes.
How embarrassing. Like if you have I said to you, well, if I'm at a dinner party and I have lots of liquid, and then if I'm going to get up to go to the washroom, I better get there. Because it's if the bladder's too full, I've never peed my pants. I mean, where's some wood that I can knock on because I haven't done that. but I feel close to it sometimes. And it's just this thing where I go, I'm weak. Like I'm, it's a weakening. You don't feel strong. You don't feel strong. So, and then that's the next level is another question behind that goes, well, what's wrong with me? I mean, everybody pees. You talk to all the women that go, oh my gosh, you totally pee. I can't jump on a trampoline. And you said to me, that's not normal. And I'm going to help you with that. And I said, you mean to tell me that I'll jump on a trampoline and not pee my pants? And you said, yes. I was like, what?
Yes. And there's a lot that goes into that too, Lori. And it's, that's a really good point to bring up, because sometimes we think it's all about strength and, I'm just not strong enough. And this is something that I'm always going to deal with. And the fact of the matter is that everyone's body is so unique. And so what I find is that it's not always a concept of just being strong or weak. Sometimes it's the strategy of how we do the movement. Sometimes it's our posture. Sometimes it's muscle imbalances. And those are the really interesting things to see. So as you come in as a new patient, I pee when I jump on a trampoline. Okay, let's dive into that. Let's look at your standing posture. Let's see what happens when you bend your knees. What's your breath doing? What's your diaphragm doing? What are your oblique muscles doing? What's the fascial integrity of your pelvic floor? Can you actually recruit those muscles? Where is your uterus? Where is your bladder? And then you were asking about the ultrasound. So when we bring ultrasound in is when we're interested in what's happening in the abdominal wall. So postpartum, and basically women are postpartum once they've had a baby. So when does that end, right? So when this magical time that we're
it needs to be really
right?
endless postpartum, because
exactly. Yeah. And so what does that actually mean? Well, we just know that when you're pregnant, that poses a lot of challenges for your body in terms of being able to deal with force and load and how you manage that in everyday tasks. So imagine that your belly has been stretched, your core, in quotation marks, muscles are not working effectively. And maybe you've had a vaginal delivery, maybe you've had a C-section, maybe you've had a little bit of tearing or stretching of the muscles and fascia in your pelvic floor.
And you're asking me to imagine this? Because I think it's happened.
Yes.
Imagine, if you will, your stomach stretches. I've done that.
One time, maybe 4 times, right?
Maybe 4 times.
And then we try to imagine you holding up this body in space and being able to counteract the force of gravity, picking up a baby, picking up groceries. You've got a backpack, you've got a baby, you've got, a grocery bag. So no wonder women are suffering and leaking postpartum, because the demands that we're placing on this tissue is oftentimes our body is struggling to deal with that optimally. So our job is to sort of look at the body and figure out what muscles are too tight, what muscles are not tight enough. How can we work with you in terms of your breathing strategy, your posture, the muscles that you're recruiting, so that when you go jump on the trampoline, we're going to be more successful and not have that fear or avoidance that, I can't do this, I can't do that, I have to run to the washroom as soon as I get to the supermarket, because what if I, can't get there? And those are the really things that are really hard to hear when women start to open up and really talk about the impact that this has on their lives. It's really, really, it's tough to hear, but at the same time, it's hopeful, because then we're getting down to what we need to work on.
Well, and the other piece of what you're saying too is, all this happens, but as women and in our society, we do not rest after having babies.
Yeah, exactly.
Right. My girlfriend, my best friend, Jeannie, she, I believe with her last child, she took 2 weeks, and they wrapped her and they bound her like she was thinking about her body after she had a baby. And, that was 13 years ago with her last child. I, on the other hand, what was I going to do? My husband was working. My mothers came in, but they didn't come in and spend the day and the evening. And they did so much because I'd never had a cesarean before. But About 2 weeks after that, I was carrying the baby. I was going. It was painful, but I did it. I managed. And I know there are so many women out there who they don't rest. We don't rest.
Mm-hmm.
So
Absolutely.
then no wonder why our pelvic floor or some of those muscles or our bladder drops in, because we haven't had the opportunity to rest our bodies and let things just sort of start to settle.
Yeah. Oh, no, I totally agree with that. And I think a lot of times we don't really think about that, or maybe we don't. I personally did not. Even with my background, I thought I also had a cesarean. Oh yeah, I didn't really think about the fact that my tissue would feel terrible if it was under gravity for any amount of time. Like I really didn't put that together. Yeah, just standing alone was just horrendous for a while.
And then you're always in that position. Yeah. We are always sitting and we're holding, especially in those first months. You're holding. And so then there's this twisting and you're putting a lot of pressure on your rectum. You're putting a lot of pressure and gravity is always like dropping right into the perineum and right into those spots. My perineum was so sore for a year. Wow. I didn't even know what it was. I was like, whatever that thing is between my vagina and my rectum, that's sore.
Yes. And that's a really good way to put it, Lori, because that's the true physical experience of your pelvic floor feeling lengthened. I don't want to say weak, but certainly lengthened, and, certainly the effects of gravity and that pressure system that we like to talk about, with the diaphragm and the abdominal muscles. And just that a lot of women tend to be fairly strong abdominally. And then you add 3 vaginal deliveries and a C-section on top of your pelvic floor. And then we kind of wonder about that force coupling between the strength of the abdominals and maybe the relative weakness or decreased fascial integrity of the pelvic floor. And no wonder we feel like things are falling out of the bottom. And so, I think when women start to feel those symptoms, they don't always know what that is.
Yes.
And that can be really scary. And so just talking about, hey, wow, you're postpartum, you've got a new baby, maybe you have older children as well. What is feasible for you? How can we make this work with your lifestyle? Because we also don't want to stress women out and say, well, you need to lie down on your back and put your feet up, because, that just doesn't work, right? It doesn't work all the time. So finding out, hey, do you have some support? Is there a way that we can prioritize this even for 5 minutes just to, do these 1-2 exercises? Do you even have time for 2 exercises? Maybe we just talk about how you stand and how you breathe so that we can really integrate it and we start helping women to feel like they have control and power and they can actually do something about it.
I love that. I love how you talk. That's what is so, it's just drawing me to you. I'm like, oh yeah, because you have this way about you that you've experienced this yourself, being a mom, and then you of course have seen so many women it just comes across like you really care. And you have a lot of knowledge about this as well. So you touched on something a while back, and I just want to bring it back out. You talked about stool quality.
Mm-hmm.
Can we just talk about that before we talk about the ultrasound and what you look for and how you see things, and then we'll move on from there. But I think people need to know that not all poo is created equal.
Good. I like that.
Yes, thank you.
Yes. So stool quality is a really important indicator of how our body is processing the food that we eat and our GI motility. And it also gives you a sense of how you're able to empty. Okay. So Yeah. So it's actually really important. So it's one of the things that we start talking about right away. And if you Google Bristol stool scale, you will get a little chart of all the different types of stool quality. And it's actually really funny. The first time I looked at this was when I was working in an inpatient medical unit in Vancouver. And the Bristol stool scale was just up on the wall. And it was just kind of accepted that we need to know how people are pooing. And it started to become more normal. And I thought, oh, when a baby is first born, all anyone cares about is what their poo doing. And then we just lose it. Somewhere in life it becomes it's not okay to talk about it. So
it becomes embarrassing or whatever.
It's embarrassing. And it's just really the way we excrete the things that we put in our body. It's not that big of a deal. So, optimally, we're looking for this nice soft serve consistency stool, which means that we have enough water and fiber in our diet so that the food can move through our GI tract and it's easy to pass. Okay. So this is a big one. Your stool should be easy to pass. You shouldn't have to strain or bear down or do really anything other than when you get the urge, you go sit on the toilet and you do your thing. So
for me, one of my complaints when I came to you, what is it? Mindful complaining? What did you say it was?
Oh, meaningful complaint. Yes.
Well, my meaningful complaint about my stool was that I would, after Saley's birth, when I would have to evacuate, I would have to tip forward. Mm-hmm. And then I tip back, and then tip forward, and then tip back again. And you said, okay.
and the reason why I said that is, wow, how intuitive of you and knowing your body and knowing the position that's more optimal for you to be able to relax your pelvic floor and to let your stool come out, because you now had to kind of figure out how to do this differently in order to make it easier on you.
Yeah. And I think we all, and so for our listeners out there, that is a real key. When you know your body and you begin to understand, and even if you don't know your body and you're feeling like this might not be the right movement, mm-hmm. or if I'm pushing or straining, I need to talk to somebody. Mm-hmm. That's essential. And I just went to different people until I found the right person.
Oh, that's so good to hear. That's so good to hear. And Lori, I think it's, we're sometimes so afraid to talk about it, but sometimes it's such a easy and quick solution.
Yeah.
Sometimes it's just playing around with increasing water intake. Yeah. Sometimes it's really just listening to the urge and going right away. Because what can happen if our stool just sort of sits on our rectum, if it's too hard, then people have trouble voiding that. And that gets to be when you have to push or strain, and you end up with hemorrhoids and really trying to evacuate that stool when it's hard and compressed and compact.
So one thing to be watching for is if you're taking care of your pelvic floor health, your stool is one of the first signs.
Yeah, I think stool quality for anyone is important, regardless if you're concerned about your pelvic health. But sure. It's definitely one of my top 5 questions.
Okay.
How are your bowel movements?
Yep.
Do you go regularly? Do you have to strain or bear down? Do you ever feel like you can't completely empty your bowel? Like there's something maybe left in there? Because if you just say to someone, is your bowel movements normal? Are they normal? Oh, yeah. No, yeah, totally normal. No one wants to talk about that. No. So you really need to probe and find out, hey, what's actually going on? What's the stool consistency? And I will bring out examples until we find out what exactly it is. Or show the stool scale.
Yeah.
And then we get a sense. Yeah, that's really easy to do.
So then after that question and that process, then you said to me, okay, so now what we're going to do is we're going to get you to lay on the table, and I'm going to bring in an ultrasound.
Yeah.
And so just kind of on wheels, and you came over and you said, okay, let's just take a look. And you had me do things that I was just really, it was interesting. So you said, so squeeze your rectum. And when I squeezed it, I could see it on the ultrasound screen. And then you were able to see what was going on inside when I squeezed my rectum, or when my favorite was you.
Oh, yes. I remember now.
You're like, squeeze your rectum. And it was like this. Okay, listeners, it was exactly like this. I kid you not. All right, so squeeze your rectum. Very good. Okay, now contract your vagina. Now squeeze like you're doing you're pulling it up. Okay, good. Now nod your clitoris. I was like, my clitoris nods? Are you kidding? I didn't know it did that. And then I had to literally sit there and go, I think I'm nodding my clitoris.
Oh my gosh. Oh, yeah. I love the cues. And it's good to get a little laugh in too, right?
Of course.
We're just not really aware of this whole area. Sometimes for people, this is just like a dead zone or a black box, and we don't look and we don't activate and we don't think about what those muscles do.
But I love that you said that. It is a black zone. It's like a dead spot where people go, okay, well, that's there.
Yeah. That's there.
That's there. This is here. But that's there. And I've even associated, like, I actually had a thought today. I thought, well, I think I'm pretty. Like, I think I'm, magnanimous. I'm charismatic. I believe
Absolutely.
I'm pretty. But then if I'm talking about my rectum, that's like ugly. And I just had that thought, and I thought, well, I'm letting it all hang out there today. So we might as well talk about that, because for a lot of people, we think, well, if I tell someone I have a hemorrhoid, that they're going to think, like, it's going to take away from who I am. It's weird that our thoughts are so strange. This is our body. We have to be good stewards of our body and take care of it in its totality. And what you are saying today is, this isn't a dead zone. And if it is a dead zone for you, then allow yourself to just hear the message in what we're saying, which is, you are important, your body's important, and we need to choose ourselves. And in this episode, on this show, we give everyone permission to choose themselves and come as you are into the situation, because it matters. And so back to the squeezing the rectum and nodding the clitoris, and what you saw was a little bit of a bladder during some of my births, I would imagine. And then just with the recovery and me not understanding and not knowing about pelvic health, my bladder dipped in to the vaginal wall, which I didn't really know. So the anatomy of the pelvis is what?
Right. So that's a really good question. So the ring of the pelvis, the bony ring of the pelvis, is made up of a couple of different bones, but you could just imagine it kind of like a salad bowl with no bottom, or like a ring. Let's call it a ring.
Okay.
So the bony part of the pelvis is made up of this ring, but all the way along the bottom part of that ring. So imagine now your salad bowl, the part that makes up the bottom.
Yeah.
That's all connective tissue, fascia, muscles. So you can imagine how important it is to take care of these muscles, because they've got such a huge function in terms of supporting your organs, allowing for intercourse, birthing babies, evacuating stool and your bladder. And they also have a closing function, right? They have to maintain your continence and hold everything in and shut off the urethra. And really, under gravity, they're just sort of acting as a little bit of a hammock almost.
Okay.
So that's really what we're looking at in the pelvis. And so when we see it on the ultrasound, it's really neat and such an awesome teaching tool where someone can see, oh, wow, there's my rectum,
Yeah.
there's my bladder, there's my uterus, there's my muscles contracting, and this is the trajectory that it's going, and what does that mean?
Yeah.
So for you, like you pointed out there, Lori, you had a cystocele, which is just that the bladder is sitting down a little bit further into the top part of the vaginal wall. So it's basically just a weakening of the top part of the vaginal wall so that the bladder, which just sits on the other side of that, is just going to sit down a little lower, like it's, sitting lower in a hammock.
And that puts pressure that causes, like, as you move in that you're in gravity bears down, it does tend to, you feel it.
Yeah. And what's interesting, Lori, is that some women are very symptomatic and some are not. So for you, for example, you had no idea that there was this little bit of bladder just sinking down a little bit. And so what I think is important is just to say to you as the patient, okay, this is happening. You're not noticing it right now. It's maybe not a big deal for you in terms of what's happening with your pelvic floor. But just as an FYI, later, if you start to notice differences with your urination, if you're starting to notice that you have to pee more frequently or your stream is changing, those are symptoms that could indicate your cystocele is becoming more symptomatic. And at that point, then we would sort of investigate that more. But it can be totally fine to have a bit of a cystocele and a rectocele, and for a patient not even to notice that. So it's really more how it impacts you.
Okay. And so then you also notice, like you said, so this would be the bladder, here's the vagina, and then here's the rectum underneath.
Yes.
So,
perfect.
And then, so the bladder was pushing a little bit on the top of leaning into the vagina, but the rectum was also leaning in to the vagina. Now, this is where I think as women, this is where all the wheels fall off, because I've heard stories, one after another, when I've been talking to people about going and seeing you, people saying to me, I need to insert my fingers into my vagina when I'm having a bowel elimination because there's no other way to do it. And other people are like, I don't have that, but it's what I have is tough enough, and so I'm like, it's really interesting. And if we can just begin to give ourselves that permission to say, okay, it's okay. It's validation. This is a validating show for people to know you're not alone, and you might feel embarrassed, but guess what? There are health professionals that can totally help you. So with the rectum, that was pushing up into my vagina. And then what was happening?
Yeah. So what was happening there? So the back wall of the vagina had been a little bit more stretched or lengthened so that when contents come into the rectum, then those contents will often bulge into the back wall of the vagina. So that specifically is called a rectocele. And then what you're talking about with inserting the fingers vaginally and then just pushing back down on that bulge is called splinting. And that helps you to have a more complete bowel movement.
Wow.
By just giving that back wall of the vagina a little bit more support, so that the stool can actually come out properly.
And if you ever saw someone with that, a patient that had what you just mentioned, then you would give them exercises, or there might be something that they could insert that would give them the support on the back wall, so that they could begin to naturally and strengthen the rectum to flow naturally? Is that?
Yeah. So it's interesting with rectoceles because the most important thing there is, always coming back to stool quality.
Right.
So if your stool is hard, you can imagine it coming into the rectum and then really impacting and taking up that space that the back part of the vaginal wall is stretched. So it's really going to come in there and kind of stay there and be pocketed. So if the stool is soft, then it flows out more easily. Okay. It comes up more easily. Less worrying about splinting. And splinting is typically just with your fingers. You don't really need to use any additional instrument.
Okay.
But then it would be sort of working on toileting position. Can you get your hips open? Can you get your back long? Is your tailbone open so that the muscles of the pelvic floor can open and the rectum can open to allow you to relax and have a bowel movement? So the pelvic floor is so interesting, where a lot of times people actually need to relax and work on muscle tension, releasing muscle tension in order to be better, whereas sometimes you need to strengthen. But the relaxing part is often overlooked. And
is that right?
Yes. Yes.
We'll get there.
Yeah. So that was the rectocele. And we talked about ultrasound a little bit, and I did want to go back to that. So typically when we're doing an ultrasound, someone's telling me something that, I really need to investigate what's actually happening. I want to know what their contraction is. I want to know maybe where their organs are sitting. Oftentimes postpartum, we're looking at a diastasis. So we're looking at the recruitment strategy of their abdominal wall. And that's all encompassed in looking at the whole person, their posture, their body mechanics, what's their alignment. So it's just one piece, but it can be a really powerful one. And it's really nice for the patient to see what's happening inside.
Well, it was really important for me to see that. I had not, I've seen ultrasounds before, but, with a child in there. This was just more about the beginning for me, where I went, oh my goodness, I chose myself today. I came to you. I see this and I'm taking care of this. That was my first step. And, and the way that you conduct yourself professionally is, I think, part of the experience for me. Because watching you were very descriptive and showing me, this is this, and here's what that is. And this is, but don't worry about that. That's going to be okay. And nothing to worry here, And then of course we move in to, then you had me get up off the table and you said, okay, now I'm going to look at your body. And I thought, wow. And then we began the discussion and, okay, so your left hip throws forward and then this happens and this. So it's not about just having a baby. It's about the whole life story of when you were a kid and you ran and you jumped off your grandfather's garage and you thought you were superhuman. We used to do that. We used to run and jump off and land on 10 feet onto the grass and roll. And it's those moments where you might have, done something to your body. And then of course, we're harder on ourselves as we get older. And we're not eating maybe as well. And then you've got all these things that work together to create a whole, to create a story. And for me, I said to you, well, part of my story is that, a year and a half ago, I was slalom water skiing and I dropped my ski and I went to put it in the back and my toe picked the water. It torqued my leg and I had this huge knee thing. And you said, okay, so you began to identify that. And you also confirmed that, this accident, if your pelvis was a little bit more, if your core was a little more stable, you probably wouldn't have hurt yourself as bad. And again, it moved me back to self-care. It moved me back to being a busy woman with 4 kids and doing all those things. But, the body doesn't lie.
Yeah.
The body tells the story. And it's the person that looks at it and goes, okay, I'm piecing this puzzle together. And you did that very well. And so in conjunction with us looking at the pelvic floor, we're also looking at, your glutes that are tight, your hamstrings, and how the body pulls and moves as we, do the small movements that happen every day.
Absolutely. And that can sound like a lot, Lori, but actually we can make that really specific based on what's most important to you. So for you, for example, if it was a bowel movement, okay, we want to see how you're sitting on the toilet.
Yep.
Let's see you do a squat.
Exactly.
And this is all Exactly. Yeah. And this is all based off of Diane Lee's integrated systems model, which is, we didn't talk about that in the intro, but that's a big part of the training that I've done at this clinic that I'm currently at. And that's the whole body approach, looking at rotations and translations and integrating into a meaningful task. And that whole systems approach is the Diane Lee, her integrated systems model, which is awesome. Really,
yeah,
really cool.
Because I appreciate Diane Lee she created that. That's her model. And I love that. And that's a lot of her research and her hard work and her dedication. But what she's doing there has completely impacted my life. And so if she's taught you that, and if you've learned that, then she has impacted me. And I know she's impacting others, because the whole body approach is, I cannot say enough. Like you said, okay, so if you're having a bowel movement problem, which you did say to me, then how do you squat? And when you saw me squat and I said, tender on the knee, all these, you were like, okay, so what if I did this to you and you moved me? Now squat. And I was like, I heard the angels singing. I was like, oh my gosh.
Yes.
Right?
Amazing.
It's so weird. And then you get a glimpse into seeing what pelvic floor feels like if it's back in the right spot, or, you know what I mean? If it has the right stability in different places. So after that, then you said, may I do an internal? And of course I said yes. And you were like, I'll leave the room. I said, don't even worry. I've done this too many times. I took my clothes off to get myself in this mess. Now I gotta, my 4 babies. I love them. Yes. But my first child was 21 years ago.
Wow.
And I never had pelvic floor care.
Wow.
So for 21 years, I've birthed babies, I've done what I've done, and I've always battled with the one thread, which is the bowel movement pressure. When I have my menstrual cycle and I have pressure in my vagina, or like a tampon will go in and it'll come out, because I'm like, how come I can't hold that? Right? Like, it's crazy. So, you went in and you said, okay, and I'm going to tell you, listeners and ladies who are going, oh, well, I'm not doing this because she's got to do an internal. I'm just saying, please reconsider, because it isn't like a PAP exam.
It's not a PAP.
This isn't like that. This isn't like that at all. I want you to explain this, because I was on the other side of it going, wow. So when you go in, it was like you were just, like we were talking about the salad bowl, you were just, you were feeling for inconsistencies in the muscle tissue or like scarring, and you would just push on it gently, and it was like it would just go, psh, like it was just releasing.
Yeah. So, the internal piece is so important. And, Lori, I will say I don't do an internal on everyone. It really has to be clinically relevant.
Right.
So, if we do the posture scan, we've got the most important task, we look on the ultrasound, I might say, you know what? I think we've got enough information here.
Right.
I don't think we need to go internally. So I try to use that wisely and use it when it's clinically relevant. And obviously when the patient has consented and they have full knowledge of what we're doing, we update them the whole time. If you have any discomfort, then I need to know. And there's always that going back and forth and checking.
Absolutely.
So absolutely, that just has to be said. And so when we initially look at the pelvic floor, we can actually tell a lot by even just looking. Yeah. So seeing what's the tissue looking like at rest, is there good blood flow? Is there any vaginal atrophy? Is there any scar tissue, old scars here that I can see from a vaginal delivery or in a episiotomy? At rest, are the muscles tight? Are they relaxed? Are they do they have increased laxity? What happens when you cough or you sneeze? So for women who are feeling like, ooh, I don't know if I feel comfortable with that, let me just say that we can actually do a lot by not doing an internal.
Right.
But an internal is really handy when we're sort of thinking, okay, you're telling me this about your bowel movements. We saw this on the ultrasound. An internal would really help to confirm my hypothesis of what we're thinking is going on with you. And 3 vaginal deliveries and a C-section, I'm kind of thinking there may be some muscle imbalances. Maybe the right and the left sides of the pelvic floor are not working in symmetry. Maybe you've had a little bit of nerve damage or you've had some muscle tearing. So I really want to see, is the continuity of that salad bowl intact, or are you higher tone or tighter on your left versus your right? When you do a contraction, do we feel the back part of the pelvic floor lift up and pull in, which is really the contraction that we're looking for? And then we can see the position of your organs. So fascial integrity. Is the bladder sitting down a little bit further? Where is the cervix? Where is the uterus? Where is the back part of the vaginal wall? Or is there any rectocele? So there's quite a bit that we're looking at. And so just gently sweeping from right to left sides, and you're right, it's just like a salad bowl. Yeah. Or when your finger is internally, it's almost like a clock face. So basically from 12 o'clock where the urethra is and 6 o'clock where the tailbone is. Right. And there's 3 levels of muscles that we're looking at. And it's basically, assessing all those muscles. Are there any deficits? What's your contraction like? How can you relax? And can you bulge, which is how we assess prolapse. So that is often the most uncomfortable thing for people to do. And having been assessed internally myself, someone asking me to relax my muscles, create some intra-abdominal pressure and push down. I mean, that's the last thing you want to do. But it is a really important piece to find out, okay, what does this tissue do under load? What happens if you lift something really heavy, or you're coughing, or you're sneezing, or you're laughing? And we can assess that really nicely when we do an internal. And sometimes we'll even have people stand up, because when you're lying down, you get one picture of what the pelvic floor is doing. When you stand up, that's a completely different situation. So sometimes that can be really helpful too.
Well, and I know that all the things that you said, they're so true. And like when you did the internal, I remember you just talking to me and telling me, okay, so I see a little bit of scar tissue here. And I had my 3rd child was posterior.
Oh, yes. Yeah, right.
Right? So then again, that pressure on the rectum and the pressure, in the perineum, it was really, really difficult. And then, but we talked about, sort of the letting go of letting go. Because you're in there and you said, you're so tense. And you could feel, and that's the benefit of being able to just have an internal and to get a sense of that. Now, you could probably get a sense, like you said, whether you're doing an internal or not. It really is case specific. But for me, it was a message about my life.
Yes.
It was a message about my life.
Yeah.
And I think I told you that. And I'm pretty sure I said, you mean in real life or right now? You said, which would you prefer? I said, right now, please. I don't need to let go and anything else. And we had a good laugh about that. But what you discovered and what you taught me in that small moment we were together is you said, I need you to let go. I need you to start letting go. Your muscles are so tight. And I went, okay. And this is a real lesson for me. And you showed me how to be and to relax my pelvis and to not clench it. And it's clenched all the time. I didn't know that. And so when you drew my attention to that and you said, nope, you're still not letting go. More. I let go. And I was like, oh my goodness, that's what it feels like.
And I will say, Lori, you have amazing body awareness. So sometimes learning to let go takes a couple of sessions. Right. And it's sometimes like meditation. Sometimes you're doing lots of breathing.
Yeah.
But for you, with your background, it was just like, boom, you got it immediately.
It was
and so that impact was just fantastic to see. So amazing.
Yeah. Yeah. But I think, we hold a lot in our muscle tissue.
Yes.
Right?
100%.
And so then the whole art of letting go is another story, another thing unto itself. But it's if there is a case for holding emotions into our muscles, that was a really good experience for me to realize that, I was clenching, I was tightening, and you showed me how to relax, and it changed the way I evacuated my bowels. It changed a lot of things because there was some twisting in there a little bit.
Yes. Yeah, exactly. And I remember, Lori, when we got you standing again in another session, it was almost hard for your body to reorganize itself after that because, I think we had kind of decided because of the posture and the positioning and, previous trauma, obviously you were holding tension. When we got you in standing, it was like, well, if I don't grip, like, what do I do?
Yeah, I
can't
had no
stand.
Idea. Yeah.
Yes. So then we really had to break it down. Okay, can you unlock your knees? Can you find center in your hips? Where were your hips? Where's your pelvis? Where's your chest wall or your thorax over your pelvis? And so, that alone, just finding neutral alignment was, I think, a big reason that helped you stop gripping your pelvic floor because you were compensating. You were trying to find support somewhere.
Yes.
And that was in your pelvic floor.
And I was doing that both in my real life.
Yeah.
And in my body. And my life was telling my body, and my body was responding to my life. And it was this cycle. And I walked out of there, and my partner phoned me and he said, how did it go? And I said, well, she just told me to let go. And he starts laughing. He's like, oh my gosh, Lori, how did that go for you?
Oh,
I said, well, it was okay. And I told Jeannie, who went to you as well, I said, this age-old thing of letting go came up. Here we are. And now I'm supposed to deal with this. And I realized I was clenching and holding, and I didn't know how to let go. And I believe, too, as women in our lives, in the real world, some of us are struggling with letting go. And we hold it, we're clenching. And it's when you relax it, you realize it's not that bad. But like you said, you have to completely reorient yourself to how to walk, how to live, how to be, and to have that awareness about, oh, I am clenching now, relax. Yes. I'm clenching now, okay, relax.
Oh, yeah. And it can be so frustrating because your brain, it's familiar with that pattern. And so it is a little bit of motor retraining in terms of telling your brain, hey, that's not the strategy that we're going to use anymore. And this is the new and better strategy.
Yeah.
And it's hard to let go of those patterns sometimes, and they sometimes come back. But for the most part, when you can start to recognize it and be aware of it and feel that in your body, then it's actually really easy to sort of say, oh, there I go again. Oh, there I go again. And then just keep reiterating that message.
Absolutely. And I've been able to do that. You woke me up a little bit. And I want to thank you for that because that was really important. Anything else on the pelvic floor health that we haven't talked about?
Oh my goodness, Lori, there is so much we could talk about. But I think in terms of, how we're approaching the body from a physio perspective, how we greet the patient, how we're finding out what's important to them, doing the assessment, the brief Coles Notes version of an internal assessment and ultrasound. I think that's probably covered that portion of it. But, we could do a whole session on diastasis rectus abdominis. We could talk about prolapse more. But I think, we've sort of addressed what we're typically looking at postpartum and that period that stretches, for the rest of the life.
When do you recommend, so if I've had a baby, when do you recommend coming in? Because, after you have a baby, you don't want anybody touching you for a long time. You're like, oh no, don't touch me. But yes. It is really important.
Yes. And so typically we'd like to see women maybe once or twice when they're pregnant. Okay. Ideally, that doesn't always happen. But certainly 6 to 8 weeks postpartum. And if you've seen your doctor and got the all clear to have an internal, then that's nice. And if you haven't, that's okay. We can always do external things. But, kind of how we talked about, a lot of women are feeling like that is a no-fly zone and that like black box situation is really happening. And I think it's important to honor that and Absolutely. Say there's so much to work on postpartum, from posture, tension release. We can work with the ultrasound. I mean, there is bags of stuff to do. We don't need to go internal right away. Yeah. So whether you come at 6 weeks or you come 10 years postpartum, it's never too late to come in. And honestly, we can help you at any stage of the game. So ideally 6 to 8 weeks, but it's a pretty tough call. I mean, you're leaving the house, you've got to get childcare, you're bringing the baby with you. This is a huge stressor. So I think we see some women that come in that early, but I think for most people, it's probably around the 4-month mark that they're feeling like, okay, I can make it out to this hour-long appointment. We're okay with a feeding program. Someone's going to take care of the baby, or I feel okay letting them nap in the clinic. And, so we have to figure out those things too.
I want to talk about the next piece. I kind of broke it up into 2 phases, but I do want to talk about the rectum. I want to talk about rectal spasms, rectal strictures, prolapse, hemorrhoids, fissures. I want to talk about that with you because I think there's this is a very important conversation as well. So we'll probably put this show in 2 parts, as in part 1 would be about the vagina, and then the part 2 is going to be more about the rectum. And so if you're listening and you don't want to listen anymore, then just, we're going to start talking about the butt.
Perfect.
You say more. Perfect and everybody goes, ew. What's that? Yuck. But you know what? And that's the thing. And we've said this all along. We've said this. There's a stigma attached to this. You're saying you have a bum. Everyone has one. Everyone has a rectum. Everyone has an anus. Yeah. And it just is. Like, this is not new information.
Yes. And I think that when we phrase it like that, these areas become less supercharged with anxiety, and the meaning of it becomes less intense when it's just, we just need to have a bowel movement. It's not a big deal.
Yeah.
Let's just be grown up about it and deal with it if it's not working properly.
Right. So if someone were to have, what is the anatomy of the rectum? Because in order to start talking about spasms and hemorrhoids and things like that, which happen after having children, can you talk to me about the anatomy of that?
Yeah, absolutely. So we have different parts of the colon, certainly where food gets processed further up the chain. But probably the most interesting part is sort of the end of the line, and that's into the rectum. And so we have different layers of muscle there. We have smooth muscle, which is regulated by our autonomic nervous system. So the system that just runs in the background and is in charge of lots of very important functions. And then we also have sympathetic muscle fibers or muscle fibers that are under conscious control. So when we talk about stool coming into the rectum, the body is so amazing that we have these receptors, these stretch receptors that tell us when the rectum becomes distended, sends a little message to the brain, oh, I've got a little bit of stool in the rectum. And not only can you typically feel, if your bowel is healthy, you can actually feel the quality of the stool when it comes into your rectum. So pay attention to that. It's really interesting. So your muscles can pick up if that's a loose stool, because that's typically harder to hold and more irritating to the bowel. And then that signal gets a little bit stronger to the brain saying like, oh boy, we better get to the washroom quickly.
If you're dancing...
Yes.
Dancing in one spot, or you're like in the movie Bridesmaids where you just sit down in the street and you just...
And then it's just over. And then it's like, no one can help you now.
You're done. You're embarrassed. It's your embarrassing story for your life.
Yeah. Own it. It's all good. It's all good. Everyone's got one.
Yeah, everyone does.
Everyone has one. So the rectum is such a complicated and amazing part of the body when you think how much our nervous system does for us at that really primal or autonomic level that we're just totally not aware of.
Right.
And I think we often take it for granted.
Right.
So when something's not going right, it's really distressing. So typically we get this signal, stool comes into the rectum, and typically when we get that urge, we should pretty much act on it fairly quickly.
Yeah.
Whereas with the bladder, we talk about different urge control techniques sometimes. But if the stool's in the rectum, your body's telling you, okay, this is an optimal time for me to void my bowel. And so that's when your external anal sphincter, when you're in the appropriate location in the washroom, that those muscles should relax and the levator ani muscles should relax to allow for the anal canal and the anal sphincter to open. So typically that happens, but sometimes it doesn't. And with you, Lori, I think there was some muscle imbalances going on there that made it harder for you to fully relax that sphincter. And so you were ending up with some issues there with your voiding, and it can be really painful. You can get hemorrhoids. We shouldn't be having dysfunction there. And then the autonomic nervous system, or those smooth muscle fibers that are further up, will actually just kind of squeeze gently and move the stool out of the rectum.
Right.
And yes, so we kind of have the background system and then our more aware system that will tighten the sphincter if it's not an appropriate time to void the bowel, or can relax when it is appropriate. And those two little functions can cause a lot of havoc for people, because voiding your bowel is such a socially appropriate thing where it's not always appropriate.
Right.
And so having that control is so important for people. Patients who say like, wow, I really worry that if I let go of a little bit of gas, I'm not sure if that is stool or if that is gas. So when those receptors start to go a little bit haywire, people will often start to say that. And that's really concerning. You're just trying to let go of a little bit of gas and then you actually have a little bit of an accident. So that's very distressing for folks. So
and if you can't feel it, even like there's some people that can't feel the stool coming in, and that there's even an urge to go to the bathroom, and then they just eliminate as well.
Yes. So there's lots of different reasons why that can happen. And sometimes that's coming from the higher motor control centers. So say, for example, with, say MS, for example, where the brain centers aren't functioning properly. And so those nerve fibers, those autonomic nerve fibers aren't actually working properly. So sometimes we don't have urge, and it's because of those things that are going on. Or sometimes there's nerve damage locally, and that will decrease urge. Sometimes there's been some trauma. So we have scar tissue or strictures. You were mentioning that. So it makes it hard for the smooth muscles to do their job. We call it peristalsis, which is basically just picture someone squeezing a flexible tube to allow the stool to come out. So if that if those areas can't optimally contract and relax via strictures or nerve damage or what have you, then it makes it difficult to have a bowel movement.
What about if you have, so you have like dairy intolerance or like colitis or some sort of, if you have an intestinal issue or a health issue that results in, there being rectal strictures, fissures, and those sorts of, and prolapse and all that, then like you have to sort of do you treat them together? And like how does that work?
Yeah. So if someone's coming in with some of those concerns, and a fissure is a good example that, they would need to be followed by a GI specialist, because a fissure is actually a tear in the rectal canal. So that's where, we're more concerned about letting that heal properly. And so where we work with that is, again, relaxing muscles, making sure they're in an optimal voiding position to have a bowel movement easily. Can their muscles let go? What's their stool quality like, so that it's nice and soft and easy to get out? Definitely with some of those other conditions you mentioned, like ulcerative colitis or IBS, oftentimes I see people with a lot of abdominal pain and, they're having these voiding difficulties, and there's oftentimes an issue with the pelvic floor as a result of that. So the muscles are either too tight, or we have muscle imbalances. Maybe we have tightness in the abdominal muscles as well. So it's basically all the same stuff. We're just really focusing on how they're having a bowel movement. But, the muscle release, working on breathing strategies, toileting position. Sometimes we'll refer to other professionals like naturopaths to get the dietary stuff really dialed in, because sometimes that can be a really important piece.
Yeah. And so anal fissures it's inside, like in the lining?
Yeah, so imagine the rectum as just like a tube. So it would be actually a tear in the tube itself.
And that heals.
Yep. Mm-hmm.
But it is probably ridiculously painful.
And it's hard to heal, because you can imagine that your bowel is working pretty much all the time.
Yeah.
So it's pretty tough, and it does sometimes take a while. Sometimes people need to be on medication as well to help that heal. So really, you just think, what's the least amount of stress that I could put my pelvic floor in? And we really try to, release any restrictions, just work on.
So when you're releasing a restriction, what does that look like for you as a professional?
Yeah, and it would just sort of depend, Lori, how they're coming in. Say, for example, with a restriction, like imagine someone with an anal fissure, like how much pain they must be in. So glutes are tightened, tailbones tucked under, abdominal muscles are contracted, and then they're trying to void from a closed opening because there's pain and there's spasm. So it would basically just be, getting the pelvis in a more optimal open position, relaxing the hip muscles, working with maybe some belly massage, releasing the glute muscles. So that could be, soft tissue techniques. It could be dry needling, but probably more soft tissue techniques if someone's in that much pain. With an anal fissure, I wouldn't be doing an internal, but we can certainly sort of work externally.
Can you actually go internally into the rectum and see if there's scar tissue in there?
Yes.
And then what happens? You can release it in the same manner?
Yeah. I mean, it's just, it's just another canal. It's just a muscular canal. And actually through the rectum, you can get really good, really excellent muscle release, and coccyx mobilizations are typically done through the rectum. And that can be really helpful if you've had a tailbone injury, or maybe a fall in the pelvis, maybe a tailbone injury during pregnancy or delivery. Yeah. So I would say it's one that I don't do as often. Just knowing, I feel like, yeah, it has to be very clinically relevant. Let's just put it that way.
Absolutely. Because it is it's a sacred spot, right? Like it's just something about it. It just feels so vulnerable, but yet the person is in so much pain. And, I've never had a fissure, but I know people that have, and they just say, it's like, it's just so much pain. And so you're saying that some of the things that can contribute to that is if you're closed, you're kind of closed in because your tailbone is pulled up rather than open, and you want to open something that's closed. Mm-hmm. And I thought that was an interesting thing. So there are exercises to open up that spot. There's exercises to open that. Okay.
Yeah, it's almost like trying to open a closed door. I mean, imagine kind of banging on a door and the door just not opening.
Right.
And fissures, they can certainly happen as a result of having those postures or positions. But I would imagine with pain, imagine a dog that's scared and the tail tucks under. That's kind of the position where, when you're in pain in your pelvis, that's kind of the position that you take. Yeah. So hard to open and void properly when that's going on.
Okay. And then for hemorrhoids, so this is one that I have struggled with. And like, so you're saying, eating well, and all of that, but sometimes that doesn't help. Mm-hmm. Sometimes it doesn't help.
Yep.
So you can, what am I doing?
Yeah. So, going back to looking at what are the pelvic floor muscles doing in terms of the rectum, doing maybe some rectal release around those muscles to really open up that back passage so that those things are happening more automatically. Kind of same thing that we did with your pelvic floor would be rectally releasing that area. So you could properly void, because if you have good stool quality, you're doing all the right things, you're drinking enough water, but you're still ending up with hemorrhoids as a result of pressure on those veins in the rectum. We still have to go back and look at, okay, so why is there that pressure? And then is that something muscularly? Is that happening due to positioning? And then figure it out from there.
Well, then if you're sitting all the time, right, then the gravity is pushing down into that space. So if it's not strong, or right, like if it's long, as you would put it, because you're not using the word weak or that sort of the word to describe it. So you're using the word long. If the muscle is long in there, then there's not a lot for it to hold. Like, what creates the hemorrhoid and the dropping down? And it's just like the pain. If you have to push that back up inside, it's so hard. It's just not, it doesn't feel right.
Mm-hmm, mm-hmm. And I think, think of something that would create more pressure. So imagine, sitting or standing or running. I mean, that typically shouldn't cause pressure issues.
Squatting.
In terms of hemorrhoid. Even that, Lori, like, I think it would be honestly more bearing down. So imagine you're constipated.
Okay.
Imagine you're pushing or straining to have that bowel movement. So imagine, more like constipation would probably cause that. Or not relaxing around that external anal sphincter.
So just holding on, like just tightening.
Oh, yeah. And then imagine trying to evacuate against a tightened external sphincter.
Because for me, it was when I could not let go until you had to. That's why my case was relevant for an internal, because you actually had to help my muscles relax and let go of some of that scar tissue, let go of some of that pain in there. And there was a little bit of a torsion. So you had to kind of straighten that out. And once that happened, everything was different.
Amazing.
Yes. And so if someone doesn't have, pelvic pain, but they are struggling with hemorrhoids, perhaps there's been, like you say, a trauma, an injury or whatever. And if there's a male listening, look, it's
the same for men.
Yes, we have to get help, right? Like no one should struggle with hemorrhoids. They hurt too much.
Exactly.
There's only so far that you can go with medication and inserting something in there to numb it or to you have to get to the root of the problem. And what you're addressing is the root of the problem, which is maybe your back is out.
Right. Could be any number of reasons. But getting to the root cause and then dealing with that and then changing the movement strategy, getting things in the right position so that they can kind of relax and let go if that's what's happening. Absolutely.
We also talked about me spilling my guts, remember? Like the front, so like this, right? Like the banana. So for men and women, that's also a part of the anus and the rectum where there's problems because you're not even in the right position.
Right. So that's a really good point, Lori. So when you're in that banana back, so if you can imagine the chest wall being kind of behind the glutes and then the hips being kind of thrusted forward.
Yeah, like move forward. Like you're carrying a baby on the front.
Like you're super pregnant or you're carrying a baby on the front.
Yeah.
And then your knees are hyperextended. So they're pushed back. And then what happens there is the abdominal wall is long. I liked how you used that word.
Yes.
It's lengthened. So we tend to get what's called a pressure belly. So you often see men and women walking around with this kind of little bit of a pooch in the lower tummy with that classic posture. And it's more that the body is kind of hanging out on the soft tissue. It's kind of hanging out on the ligaments. It's easy to stand that way.
Yeah.
But it's not optimal for your abdominal muscles and your pelvic floor.
Right. And then how does that help with hemorrhoids, with that sort of thing? Like what that posture aids in sort of that slouching, right?
Yeah. So it's amazing to even try it. So if you stand up and you lean back and put your pelvis forward and then try to do a pelvic floor contraction and compare that to standing upright with your sternum over your pubic bone and try to do a pelvic floor contraction. And you can feel the difference in the muscle effectiveness is totally different. The experience is totally different. So that's how it translates. It's just better. It's a better positioning for your muscles in order to be able to support your organs.
Right. And so then if you have hemorrhoids, then it's because the structure is not at its optimal.
Yeah. It's a finding that we say, okay, there's been a lot of pressure here. There's something not optimal that's happening. So what is that? And then we kind of go on a little hunt and we try to figure out.
It's also about if you are having diet sensitivities and you're also not eating well, if that stool gets hard, you're toast.
So oftentimes it's just drink a big glass of water in the morning. Honestly, I think a lot of folks were not drinking enough water, or sometimes a really simple fix. But if you've done all those things and you're still having, then we need to look further.
Okay. Rectal prolapse. So that's where the rectum loses its attachments that keep it inside.
Yeah. And it's actually really, really rare. So I don't think I've seen a rectal prolapse ever. So we see rectoceles, which is a little bit different. That's when the back wall of the vagina is stretched. So then the rectum kind of bulges into the back wall of the vagina. But if it was a rectal prolapse, then the rectum tissue would actually be coming out of the anal sphincter. It's not very common.
Wow. And I would imagine it's like turning inside out.
Yes.
Yeah.
So it's kind of coming out. And in. Mm-hmm.
And then, of course, there's treatment plans for that.
You know what, Lori? I think you'd probably be looking at a surgical intervention for that. I think definitely dealing with muscles that are in pain or that are in spasm, strengthening to prepare for that, absolutely. But you're probably more looking at a surgical correction.
Rectal stricture?
Yes. So that would be where you have a tightening area of scar tissue is the best way I can describe it. So if you imagine any like bad scar that you've had, how there's like kind of that whiteness to it, it kind of sometimes puckers. A stricture can be like that. So it's a real narrowing of the rectal canal, and that's typically due to some type of trauma that has caused scar tissue to build up. Okay. And so it's a real narrowing of the rectal opening. It can happen further in, it can kind of happen anywhere along the rectum.
Okay. And then is that because of the same thing that we're talking about, like the posture and that sort of thing? Or is it just based on scar tissue? And then what happens? So can it happen, a rectal stricture, after you've had a baby or during the birthing process?
Typically not.
Okay.
Typically we're looking at someone who's having some sort of voiding dysfunction with their bowel. Sometimes maybe they've had a surgery in the bowel that has then caused scar tissue to form.
Okay.
So that's typically when it's happening. So again, not as common to see that, but certainly it does happen.
Right, and that could cause rectal spasming too, right?
Oh,
because
100%.
100%?
Yeah. Oh, yeah. I mean, if you're, again, it's kind of that closed opening, and then day after day, you're trying to push the stool through this opening. And so some people do, scar tissue release. Sometimes people do a dilation technique. Sometimes that's done under general anesthesia, actually, to dilate the muscles.
Okay.
Yeah.
But all of this, most of this, other than the prolapse, you can assist this if you're looking at this, you have this. There is a way to alleviate some of the pain from this by finding out how the body works and what your strategy is. You're just so casual about it, and it's and that's what is amazing to me, is because like a fissure or a hemorrhoid or a stricture, those things hurt and your life is over. You're just like, I'm out. I can't move. I can't do anything. I can't lay. I can't stand. I can't sit. Whatever. And you're like, no, that's okay. We'll help you.
Yeah. And you know what, Lori? It's always so funny when we think about, like, say you strained your back and you were in bed and you were in so much pain and you couldn't do anything. You wouldn't hesitate to go see a physio or a chiro or your health professional.
Yeah.
But when it's to do with your rectum, it's like, no one can see me.
Yeah, and you close off.
Yeah. But I mean, we do the same thing just for those muscles, and dealing with, the nervous system and the trauma that the body has gone through, and just the way that the body is processing pain. And sometimes people will have, a surgical something done to help, but we also need to then retrain the muscles afterward and deal with scar tissue. So there's always something that we can help with along the way.
Well, this has been great.
Oh, thank you.
This. I was looking to the new year to go, this is I was very excited. I mean, I was
me too.
Thrilled to have this conversation, because there are so many. I really think this is scratching the surface.
Yeah.
Right? Like, we can't get to all of the, drill down into all of the areas today.
I feel like we did pretty well. I think we covered a lot.
We did so much in this time, and I don't believe we squandered it 1 second here. And we got to have you back on so that we can really, hone in on and drill down into some of these things. Is there anything that you just want to encourage someone with that may be struggling with one or more of these things that we've talked about today?
You know what, Lori? I think I would just say, whatever you're worried about or dealing with, however that has showed up, and whatever complaint that you have, there's something that someone can do to help you. And whether that's your pelvic floor therapist or whether that's another physio, I just think so many people just sort of brush these issues under the rug, and they're really troubling, and they can be very just tough on someone. Over 10 years, Laura, you were dealing with this, and you never saw someone. So I think when people come in and they see how quickly and how easily we can really start to deal with some issues, oftentimes we've got a box of tissues, and we use those tissues because it's just like that relief. And I think that the more that the message gets out there that there's help, I think, as much as we could disseminate that would be my last note.
Yes. And I would say that for those women who are suffering, who have had children, who are thinking that they are the only ones who...
You're not, I promise.
And I promise you, because I apparently... am using my platform well, I'll tell you. This is like, I did think about this, and I thought, this is vulnerable for me.
And you've been so amazing and so upfront. It's so awesome.
But it's vulnerable for me, and I'm willing to take the risk. I know that we have to talk about this, and the driver for me is my own family. My daughter is 10. My oldest daughter is 21. They're not anywhere near, dealing with children or anything like that. But when they are, I need them to know that I gave them as much information as they possibly can have. That we are empowering men and women that are teenagers. What can you expect? If you've got pelvic pain, if you are not pooing well as a young man or woman, you need to go and see somebody. It's there's a message in that. So thank you for being your wonderful, beautiful self. And you make it easy to have a conversation, because I can just see this as your joy. It's something that you appreciate and you like doing, and you're invested in the human condition. You're invested in the strategy of the human body. And when you started using that word, I was like, it is a strategy. Right? Because it's now become a strategy for me. I literally had never thought about letting go of my pelvis before. Until that day, I was like, now I'll look at my girls and I'll say, hey, and they'll be like, oh, and everybody starts to like unwind. It's awesome. So we're learning every day, and we're using the people around us to get information and become empowered in our own lives. And this is all about choosing ourselves. So let's give ourselves that moment to choose us as busy mothers. And this, Kjersti, being a mama,
it's no joke. It's amazing and awesome, but it's busy. So you really have to put aside that time for yourself.
Yeah, you said earlier, if 6 to 8 weeks, 4 months in is when people really want to begin to start to be thinking about their pelvic health. And you said, some moms, their babies, they have to nap and they have to do things, and it's also about picking the time. And sometimes it's not easy, but your clinic, that doesn't matter. It's like you are there for people. So if baby's having a bad day, it's okay.
Absolutely. Absolutely. And we've all been there. We know, we're well versed with that at the clinic. So, it's very accepting. And, if it doesn't work that day, then, we can make it happen another time. So there's always that flexibility. And we just want people to be seen, whatever point along the journey it is.
I love that. And you're saying it's seen as in come and visit us, and I'm interpreting it as we see you.
Oh, yeah. I think you get that sense when you come into the clinic. I mean, it's a really nice environment, and it has good energy, if I can put it that way.
It does.
Yeah,
it does.
It's very welcoming.
And if you have rectal issues, if that's what's manifesting itself in your life, and hemorrhoids and fissures and strictures and spasms, we see you. And there are people that can help you and can begin to help your life feel different. And so that is the goal. That's the message. So thank you.
Thank you, Lori. I'm so pleased to have done this with you today. It's been so wonderful.
Oh, I know. And I'm sorry it's long. I mean, we just went through the list.
I know. I'm shocked. I can't believe it. I think it's fantastic.
Yes. And thank you for being... I
look forward to many more.
Yes. Well, that's it. Thank you for being open to more, because I know people are going to want more of this. So thank you so much, and have a great rest of your day.
Oh, thank you, Lori. You too. Okay, talk to you soon.